So today I'm starting retinal detachment with you people, and it will be a short lecture, just an introduction to the retinal detachment. And so first of all, the examination of the retina. There are two types of ophthalmoscopy that is done. One is the direct ophthalmoscopy, and the second one is the indirect ophthalmoscopy. Direct ophthalmoscopy we usually do with the ophthalmoscope. There are two instruments that is used. One is the ophthalmoscope, one is the retinoscope. With the retinoscope, we are checking not the retina, but we are checking the refractive errors of the patient. But with the ophthalmoscopy, we are checking the fundus of the patient, the retina of the patient. So if there is anything like you can see in this picture, if the lens is placed between the viewing system, it means it's an indirect ophthalmoscopy. When there is no lens in between the lens which we are using on the slit lamp to examine the fundus of the patient, it's a form of indirect ophthalmoscopy. The second one, which we are examining directly with the ophthalmoscope, is direct ophthalmoscopy. Then, if there is mature cataract and you want to evaluate to see is because you will not be able to see the fundus in a patient with a mature cataract. So what you can do, you can ask for the B-scan ultrasonography, and with the ultrasonography, you can detect the status of the retina, whether it is attached or detached. Because a B-scan ultrasonography is a form of simple ultrasound that are done for the other specialties, but for the ophthalmoscopy, it's called B-scan ophthalmoscopy, or B-scan ultrasonography, or B-scan. With that, we can evaluate the status of the retina, whether it is attached or detached. Then the normal anatomy of the fundus, and this is the, you can see this is the optic disc, these are the arcades, the central retinal artery, the central retinal artery then divided into branches superiorly and inferiorly. This is the macular region. The macular region in the center of the macula, there's the fovea, and this is the peripheral fundus, all the peripheral retina of the patient. Now, because we know anatomically that between the behind the lens there is the vitreous, and the vitreous, what is the function of the vitreous? The vitreous is acting as a tamponading agent for the retina to place the retina in place, because if there is no vitreous within the vitreous cavity, what will happen? There will be no tamponading effect on the retina, and there are increased chances of retinal detachments. Now, normally, this is the optic disc of the patient. Here will be the macula of the patient. This is the peripheral retina, and these are the ciliary processes, ciliary portally. The vitreous is strongly attached. The vitreous is strongly attached at a few points, but it is very strongly attached at the vitreous base. And where the vitreous base is over here in the periphery, and it straddled the ora serrata about 2 millimeter in front and 2 millimeter behind. The vitreous cannot be detached from this region because it's very strongly adhered over here to the vitreous, and this is called the vitreous base. The vitreous is also strongly attached with the optic disc and also along the major vessels. What happens normally, and with the aging process, there is collapse of the vitreous gel, and there is molecules formed within the vitreous cavity, and the vitreous gel become just like a fluid instead of jelly, and it sinks down. When it sinks down from superior to inferiorly, what will happen? That the tamponading effect is lost. Now, and the retina, there are certain peripheral degenerations. Let's go to this slide. Yes, you can see there are small vacuoles are formed initially, and this is the normal aging process. This is more earlier than the myopic patients, and if the patient is having some pathology in the vitreous like uveitis or vitritis, then also in myopic patient, this process start early in comparison with the normal people. And what happens there is small vacuoles form, this vacuole collapse and then sinks down. Then other vacuoles are formed again, these vacuoles combine and then sinks down. And with the passage of time, the vitreous, because the vitreous is acting as a tamponading effect on the retina, this tamponading effect is lost because the vitreous will sink down. Because the jelly structure of the vitreous is lost, the collagen fibers break down, and what will happen that it will be detached. This is the normal mechanism of posterior vitreous detachment. Normally, posterior vitreous detachment starts in the perifoveal region, not in the fovea, but in the perifoveal region. Then it removes the perifoveal or macular region. then it is detached from the macula. Then at the end, because I told you that it is strongly attached with the optic disc, and it also detaches from the optic disc. And keep in mind that always the vitreous go towards the vitreous base, because this is the vitreous base and the vitreous cannot be removed from this area because of very strong attachment. Whenever, because of the trauma or because of any other reason, if the vitreous is detached from the vitreous base, it usually tear up the retina from here, and the vitreous detaches along with the retina from here. So whenever there is vitreous detachment, it starts from the posterior surface to posterior aspect, and then it goes interiorly. Like in this picture, normally because vitreous is very strongly attached with the vitreous base. When the vitreous detaches from the optic disc, what will happen that some of the glial cells are also removed along with the detachment, and these glial cells are then visible over here. And this is called Weiss rings. You people will read it in the book that Weiss ring. The Weiss rings are actually the attachment of the vitreous on the optic disc, and mostly the patients are complaining of the floaters. So that floater is because of the Weiss rings, the glial cells which are detached from the optic disc. Whenever the patient is complaining of floaters, it is very important to examine the periphery of the retina, because what will happen? Let's suppose if here is some retinal degeneration, and the retinal degeneration, the area of the retina is very weak. That is the thin area of the retina and degeneration, like in lattice degeneration. There are different types of degenerations of the retina, and this degeneration can occur in normal people as well, but the chances are more in myopes. And as the myopia increases, like if the refractive error is less than 6, this is simple myopia. If it is more than 6, then it's pathological myopia. Why it is called pathological myopia? Because the chances of pathology are more if the refractive error of the patient increases. So if there is uh, and degeneration and retinal degeneration, the retina is very weak, but the vitreous is strongly attached to the degenerated area. So what will happen? Because let's suppose this is the weak point, and this is here is the lattice degeneration. On the lattice, the retinal layer are very thin, but the vitreous is strongly attached. So if there is normal process of the vitreous detachment, what will happen? That it will be strongly attached over here, and it will pull the retina. And when it is pulling the retina, because the vitreous is normally it's the normal mechanism of the vitreous detachment. It detaches from all these areas, but here it is strongly attached. So what will happen? It will tear some part of the retina as well. When the retinal part is teared, what will happen? That there the break and the retina is formed. Now, because the aqueous is continuously formed, the aqueous goes into, and this space is then replaced by the aqueous. The aqueous will go over here, and this synthetic fluid from the degenerated vitreous, it will also passes through that break, and it will separate the neurosensory retina from the retinal pigment epithelium, leading to the retinal detachment. Again, you can see what will happen. This is the normal process, the vacuolar form, the vitreous is detached, this is the jelly form of the vitreous, and then here is the synthetic fluid, the degenerated fluid goes. Let's suppose if the retina is strongly attached, the vitreous is strongly attached to the retina over here, it will not be detached, but it will form a break over here. And if the break is formed, what will happen? The fluid will go over here and it will detach. Small break is formed initially, and then it will detach the retina. These are the various types of degenerations. You can see these small lines over here, and these are Snell track degenerations, snowflakes degeneration. These are again lattice degeneration. Lattice, the most common type of degeneration is the lattice degeneration. Lattice degeneration can occur in normal people, and there are more chances of lattice degeneration and myopia. And what's the significance of these lattice degeneration? These are lattice degeneration with holes. So the importance of the lattice degeneration is the retina over here is very weak. It can break, or the tears can be formed very easily in this part of the retina. The second thing is the vitreous is strongly attached to these degenerated area. Let's suppose this is the normal area where the vitreous will be loosely attached to this area, but it's very strongly attached to this area. Now, if there is the normal posterior vitreous detachment mechanism start, what will happen? That it will be detached easily from here, from the normal retina, but because of the strong attachments of the vitreous to the lattice degenerations, when it is detaches from here first, And usually the patients, if the vitreous is moving within the eye and with the movement, the patient will be the patient will be having symptoms of flashes and floaters. Floaters will be because the vitreous is detached, and there will be some wire strings and also some attachment of the vitreous that is visible to the patient, and the patient will be complaining of floaters. Flashes are when the vitreous is putting pressure on the retina, and the retina, with the movement, the vitreous, if the vitreous is putting pressure on the retina, the patient will be having floaters. And whenever the patient is complaining of floaters and flashes, it's very important to examine the periphery of the retina to check for any break, because if you see the white strings are there and if the patient is symptomatic, the patient is complaining of photopsia, floaters, and flashes, then it's very important to check for the peripheral retina whether the vitreous detachment has made any break in the retina or not. So the importance of the degeneration is the retina is weak over here, but the vitreous is strongly attached to this area. Whenever the vitreous detaches from the regenerated area, usually not necessarily, but usually it makes a break within the retina, and then like this, and then this is a point is formed through which then the fluid will goes to that break and then detaches the retina. Uh, there are three types of retinal detachment. One is the rhegmatogenous retinal detachment. Rhegma means break. For rhegmatogenous detachment, it is important that it must have a break. Without break, it will either be tractional detachment if there is traction or pulling effect of the vitreous on the retina, that is tractional detachment. And the third type is the exudative. And exudative, there is no break, but it's the choroidal vessels, and the RP is unable to protect the diffusion of the fluid from the choroid, and it comes to the subretinal space, leading to the retinal detachment. And exudative retinal detachment, there will be no break, and exudative retinal detachment is most commonly because of some tumors or because of the uveitis, the inflammatory conditions, not necessarily uveitis, because in scleritis, again, we can have exudative retinal detachment. So there are three types of retinal detachment. One is the rhegmatogenous, if there is break. One is the tractional, if there is like in diabetic patient, there is traction on the retina leading to the detachment. And the third one is the exudative. So these three types are of retinal detachment. You people must know rhegmatogenous, there is break, and traction if there is pulling effect or traction on the retina. And the third one is exudative, if it's because of some inflammatory condition or tumors. Now, sometimes there can be combined tractional and rhegmatogenous retinal detachment, like in diabetic patient, if there is pulling effect on the retina, and if along with the pulling, if the break is formed within the retina, then it's combined tractional and rhegmatogenous retinal detachment, because the traction is there and also the break is also formed. Now you can see these are the lattice degenerations, and the lattice degeneration, as I already mentioned, that the vitreous is strongly attached. If the vitreous detaches, what will happen? It will tear the retina, and when the retina is teared, then the subretinal space is in communication with the retinal fluid. The retinal fluid will pass to do that break, and it will detach the retina. Again, it depends that the break is formed superiorly or inferiorly, because superior break is an emergency for surgical intervention, because with the passage of time, let's suppose if the macula of the patient is attached and you examine the patient and you see that there is some peripheral retinal detachment, it's an emergency that the patient should undergo retinal detachment surgery, because within few days the fluid will gravitate inferiorly and it will detach the macula as well. And now, let's suppose if there is a break is formed within because of the posterior vitreous detachment, and the break is formed and the vitreous is also strongly attached. Let's suppose to this area the vitreous is strongly attached. What will happen? The vitreous will move. This area will also move, and when this area move, it will open up the break for the fluid entry, and it will increase the tear until and unless the vitreous is detached from this region. What we will discuss it later on in the retinal surgery. Now, there are different types of treatment options as well. Let's suppose if there is small hole in the retina, and if the patient is asymptomatic. If the patient is asymptomatic, means this area is covered, because whenever the vitreous is pulling traction on the retina and pulling it, the patient will be having flashes. Atrophic holes and myopic patient is not an indication neither for surgical intervention nor even prophylactic laser is not indicated if the patient is not symptomatic. If the patient is symptomatic, then we need to we apply laser around the hole and this area is closed. Even if the break is there and if there is no clinical retinal detachment, what we will do, that is called barrage laser prophylactic laser is done. That is argon laser on the retina, and this, because of the scarring and the fibrosis, this area is closed. The break will be there, but the surrounding area is closed, and the fluid enter into this area cannot detach the retina because already this area is surrounded by the fibrosis due to the laser. And again, we can do laser over here to limit the extension of the retinal detachment, to make a barrier to the extension of the fluid to detach the retina. Simple retinal degeneration is not an indication for prophylactic laser. Again, you can see if the break is formed, what will happen, that the fluid will enter over here and the retina will be detached. Again, depends upon, it will gravitate inferiorly and sometimes all the retina is detached. But keep in mind, the retina cannot be detached from the optic disc because these are the ganglion cells which is making, going through the optic nerve. So this area cannot be detached. And usually the retina is also attached over here because of the vitreous base, because the vitreous cannot be detached from here. Again, you can see the same process. If there's a break is formed, what will happen, that the fluid will go and it will detaches the retina, and ultimately if it is untreated, what will happen, that the whole retina is detached. Then what will be the signs of the retinal detachment? I already mentioned the patient will be having photopsia, floaters. There will be tobacco dust in the anterior vitreous. Why there will be tobacco dust, and where these tobacco dust, these brown cells come from? Because normally what will happen, if we go back to the anatomy of the retina and see the retinal layers, the outermost layer of the retina is the retinal pigment epithelium. The retinal pigment epithelium is having pigmented cells, and these pigmented cells normally cannot come into the vitreous cavity. If there is break and the neurosensory retina, what will happen? These pigmented cells are exposed, and these pigmented cells are coming into the retina, into the vitreous, and these will be visible on ophthalmoscopy as brown cells because retinal pigment epithelial cells are brown. If there are brown cells within the vitreous, it is only and only because of the retinal break. If you are not able to see the retinal break on ophthalmoscopy, but the brown cells are there, then you must look at the periphery and everywhere for the retinal break, because the brown cells are coming only from the retinal pigment epithelium into the vitreous cavity. So if you see brown cells in the vitreous, it means some break and the periphery is there. So that is tobacco dust and the anterior vitreous. Yellow pupillary reflex if there is retinal detachment, because the normal red reflex will be lost, and slightly opaque, raised, and corrugated appearance of the retina if there is retinal detachment like this, because this is corrugated, irregular, usually an rheumatologist retinal detachment. So uh, let's see, there are no slides. I have made these few slides, and because I came to know last evening that I was thinking that the college is closed and you people are enjoying your summer vacations, but I was told that still we have to send the classes, the lectures to the. So I will make the lectures, and because it was an emergency lecture, so I think it will be enough for now. And then the next class, I will talk to Iftihar Bhai. If he agrees, then I will send you. We will continue with the retina, and I will send you next class on the Monday, inshallah. Thank you very much.